Good evening, sir. My topic is BIS or entropy. BIS or entropy is the measurement of depth of anesthesia and intraoperative awareness. Why should we monitor this in during general anesthesia? Intraoperative awareness with recall is a rare and distressing complication of a general anesthesia that is associated with significant psychological complications. To prevent this, a number of methodologies and devices have been implemented during general anesthesia. The most commonly used device is BIS. Intraoperative awareness with recall, it refers to intraoperative consciousness and postoperative explicit recall of operative events. Modified Bryce questionnaire is useful and more sensitive in detecting intraoperative awareness with recall. The components are: what is the first thing you remember after waking up? Do you remember anything between going to sleep and waking up? Did you dream during your procedure? Were your dreams disturbing you? What was the worst thing about your procedure? Implications of awareness is related to inadequate anesthetic dosing for a given procedure. Patients have elevated anesthetic requirements which are previously unknown. Patients are too ill to tolerate adequate levels of anesthesia. Anesthesia delivery system malfunctions. Indications of BIS are patient factors: obesity, pediatric patient, pregnancy patient, critically ill patient, opioid abuse, previous history of awareness under general anesthesia. Anesthesia techniques are TIVA, total intravenous anesthesia, low flow anesthesia, induced hypotension, and rapid sequence induction. Surgical factors: cardiac surgery, neurosurgery, and obstetric surgery. Basis of EEG and working principles. We should know about EEG before the BIS monitoring. EEG monitoring involves the placement of multiple electrodes on a patient's scalp to measure the electrical activity of the brain. The electrical activity is portrayed by different waveforms and different frequencies and amplitude. The waveforms are alpha, beta, theta, and delta, and different frequencies. The beta waves indicate awake state, and the delta state is non-REM stage 3 or general anesthesia. Analysis of EEG data by different approaches are Fourier analysis, bispectral analysis, time domain analysis, and frequency domain analysis. After these analysis, BIS index displayed in the monitoring. BIS index is a combination of 3 parameters derived from EEG analysis. There are burst suppression ratio, relative beta ratio, and pink fast flow. BIS index is a dimensionless number of a scale from 0 to 100. 0 is a cortical electrical silence, that is flatline EEG. 100 is normal cortical activity, that is awake state. 20 is burst suppression. 40 is deep hypnotic state. 60 is general anesthesia. We should maintain BIS level is 40 to 60, and 80 is light sedation. Additional data parameters are EMG, it measurement of muscle activity, 95th percentile of spectral frequency, total power, signal quality index, and suppression ratio. The suppression ratio is indirectly proportional to the BIS value. BIS interactions are: anesthesia dose of ketamine do not alter BIS value. BIS not affected by even 75% of nitrous oxide producing unconsciousness. Beta blockers may alter EEG response to stimuli and reduce BIS values. Changes in body temperature can alter EEG signal and affect BIS index. Muscle relaxant alone can cause spuriously low BIS value and should be used with caution. Advantages of BIS is: reduces risk of awareness, reduces use of narcotics and sedatives, faster wake-up time, and shorter post-anesthesia care unit stay. Disadvantages are: falsely elevated BIS index with error in electrolyte placement or EMG activity, any pacemakers and patient warmers. Poor correlation with sedation score like Ramsey sedation score used in ICU. Clinical application are monitoring sedation and hypnosis, monitoring awareness and recall during general anesthesia. It guides optimal to titration of anesthetic doses, predicts level of sedation in ICU. Other trials and recent advances are going on. They are be aware, be unaware, BAG, recall, and Michigan awareness control study. Entropy. Entropy measures the degree of disorder or lack of synchrony in the system. It used to measure the depth of anesthesia. The technique are based on processed EEG and frontalis muscle signals. The parameters are state energy, response energy, and burst suppression ratio. State energy, it consists of mostly EEG activity, and response entropy, it consists mostly of EMG, frontalis activity. State energy is mostly low frequency, that is 0.8 to 32 hertz. Response entropy is higher frequency, that is 0.8 to 47 hertz. State energy index from 0 to 97 and response entropy index from 0 to 100. If state entropy is low and response entropy is high, we should further give analgesia or further muscle relaxant. Burst suppression ratio of suppressed activity to total activity period in EEG in 1 minute. The target range for entropy is 40 to 60. If we increase EMG activity, it indicates arousal. That's all the time.
So who actually initially told about this awareness under anesthesia?
Mostly emergency patients and obstetric patients, we won't give.
Which anesthetist is credited with the identification of a condition called awareness under general anesthesia?
Neuro.
It is not a neuro anesthetist. I can give you a clue. He demonstrated that the presence of awareness under anesthesia by a technique called isolated forearm technique. Can you tell me the name of the anesthetist who described the isolated forearm technique to establish his diagnosis of awareness under anesthesia?
Winterbottom.
Pardon?
Winterbottom.
Wintergood, no. He was called Michael Tunstall. Tunstall. Michael Tunstall was a person. He was a very leading UK obstetric anesthetist. And earlier days, you read the history of obstetric anesthesia, all cesareans were done only under general anesthesia. Okay. During early 90s only, the technique was changed from general anesthesia to spinal anesthesia because of the complications associated with general anesthesia, like vomiting and aspiration, and difficult airway tackling resulting in hypoxemia and cardiac arrest. So during general anesthesia, before the delivery of the baby, they used to avoid all inhalation anesthetic agents to prevent the uterus becoming very lax and not contracting later on. So during that time, most of the anesthetists in those days giving general anesthesia used only oxygen nitrous oxide, totally avoiding volatile anesthetic agents throughout the surgical time. So during that time, one patient who was like obese, who underwent cesarean section, complained in the next day after surgery that she could hear the theatre people, surgeon and other people commenting about her bodily status of obesity and making adverse comments about her physique and giggling and laughing, insulting her. So she recalled all these things, and really it happened because the doctors were making fun of her and talking about that. And unfortunately, or fortunately, Mike Tunstall happened to be the anesthetist, and he noticed this, and this became a big issue. And then he thought, how can a patient being induced with tapentone and then intubated with a relaxant and inhaling oxygen nitrous oxide, how can they recall? And so he wanted to establish whether there is a condition where patient can still be conscious under general anesthesia. So what he did was he applied a tourniquet to the arm, raised it above the systolic pressure so that no drug will flow to the arm before induction of anesthesia. Then he induced anesthesia with tipentone, gave relaxant, and told the patient preoperatively that after anesthetizing you, I may give you some commands like asking you to flex your right hand fingers. If you listen to me and if you are able to hear me and comprehend me, then you can obey my instructions. And after induction, after intubation with dexamethasone, we asked the patient to flex the right hand muscles, and the patient was able to carry out his instructions. By this objective method, he described that there is a condition called awareness under general anesthesia. But later on, there were a lot of questions raised on this condition, and people said it may not be true, and they did not want to agree that. But after a few years, it became established that it can happen, and that is the reason why people started thinking of using the EEG signals to identify the depth of anesthesia. Okay, so the BIS monitoring and the entropy monitoring, they come under the category of awareness and depth of anesthesia monitoring signals. Okay, so they have now become a standard part of anesthesia monitoring systems, especially in cardiac surgery, neurosurgery, and obstetric surgery, where you have to maintain proper depth of anesthesia to avoid the stimulation and other unwanted cardiovascular effects of the stimulation to happen in these patients. And this monitoring was the earlier one. Then later on, entropy came. Now all these things are there available in the market, and Soundharya has covered almost all the points. And just to give you a visual idea of what to write and what to remember, I'll just share my screen with you.